Yeah, good evening, everybody. Uh, Welcome to this World Osteoporosis Day celebration from Intouch Pharma. Now, I hand it over to the moderator for beginning of the session. Over to you.
Okay, thank you. Namaste and very good evening, all the panel members and the delegates. Let me start with wishing all of you a very happy World Osteoporosis Day. We know that osteoporosis is a very dreadful condition, which is often termed as the silent killer. We know that till the time a patient incurs a fracture, the patient himself or herself is not aware that he or she is suffering from osteoporosis. And once the fracture has happened, after that it is quite, I would say, quite late for the real management of the disorder. So yes, early management as well, early diagnosis as well as management of the disease is very important. Now, the dilemma related to the disease is not only limited only to the patients. There is again there are a lot many queries in terms of how the medical for it. So with protocols, newer techniques and newer medications coming out, there are often a lot many doubts in our minds that okay, how should we diagnose, what should be the surgical method of treatment, the optimum way of surgical as well as medical management. So definitely we need to keep on updating our knowledge in this aspect. So with this background, I, Dr. Amit Jain from Department of Medical Affairs, INTAS, on behalf of the division INARA, which is specifically dedicated to the management of osteoporosis, welcome all of you in this today's webinar, which is being held on this occasion of World Osteoporosis Day under the aegis of course, Tavya Hospital. And today's webinar is under the title of Stand Tall Against the Silent Killer. So in today's webinar, we are joined by the patron who is, all of us are very aware of him, Dr. Ajay Krishnan. And then we have moderators, Dr. Shivanand, as well as Dr. Raviranjan Rai. So once again, I welcome all the faculty members as well as the delegates and would like to hand over the session to our moderator, that is Dr. Raviranjan Rai. Over to you. Over to you, Dr. Rai.
Yeah, you need to stop sharing.
I should stop it.
A very good evening to one and all. On behalf of Stavya Spine Hospital and Research Institute, I, Ravi Ranjan Rai, welcome you all to today's webinar on osteoporosis. Today is World Osteoporosis Day. World Osteoporosis Day was launched on 20th October 1996 by the United Kingdom's National Osteoporosis Society. Since then, it has been organized by International Osteoporosis Foundation every year to launch a year-long campaign dedicated to creating awareness about prevention, diagnosis, and treatment of osteoporosis. I would now introduce the speakers for today. Dr. Devanand Degalmadi has over 10 years experience in spine surgery, which includes working in many national and international spine surgery centers, including the world-famous Rizzoli Institute in Italy. Dr. Devanand is a part of Stavya team for more than 5 years now. He has multiple academic publications in national and international journals. Our next speaker is Dr. Bharat Dave sir. Bharat Dave sir doesn't need any introduction. He is one of the pioneers of spine surgery in Ahmedabad and Western India region. He has a career spanning more than 30 years. Dr. Dave has more than 40 academic publications and presentations to his credit. He has been regularly conducting lectures, awareness programs, and even dramas on osteoporosis for the benefit of patient and public awareness. He has also authored a book on osteoporosis, which is easily understandable for patients. I am glad to introduce our guest speaker for today, Dr. Dilip Sengupta sir. We welcome you, sir. Dr. Sengupta sir is the Director of Center for Scoliosis and Advanced Spine Surgery at Texas, United States. He had his basic medical training in India, after which he moved abroad to UK and then to US to gain expertise and has made an illustrious career in spine surgery. Sir has immense experience and knowledge about spine disorders, which he would be sharing with us today. I would now request Dr. Devanand sir to begin his talk.
A very good evening. Greeting from Savya Spine Hospital and Research Institute. I am Dr. Devanand. I am going to discuss about clinical features and investigations in osteoporosis. As you all know, WHO has defined osteoporosis as bone mineral density that lies 2.5 standard deviations or more below the average value for the young healthy woman of minus 2.5 standard deviation. The basic differences between osteoporosis and osteomalacia is in osteoporosis, the overall bone mass is decreased, whereas the mineralization is normal, as you can see. And in osteomalacia, the bone mass is variable, but the mineralization is decreased. So the symptoms of osteoporosis depends upon the many factors because it is a kind of generalized disorder of skeleton. Patients may have bony pain, especially in the lower rib cage, or they may have bony pain all over the body. But the sequelae of fractures, especially in the vertebrae, the wrist, Colles fracture, and the hip, IC fracture, osteoporotic patients, they usually present with these sequelae of fractures into the OPD. Many of them in the OPD basis, in a generalized checkup, have pain in the back, sometimes a deformity of the spine. It could be a scoliosis or a hunchback like kyphosis. So osteoporosis is mainly seen in females when compared to males. Women approaching menopause by around the age of 50 start experiencing vasomotor symptoms. Postmenopausal symptoms have greater risk of vertebral fracture than any other type of fractures. By the time they are 75 plus, they usually have, most of them have hip fractures, and they end up with a kyphotic spine. The typical presentation of an osteoporotic vertebral fracture is acute in onset. A trivial trauma such as sudden bending and lifting a small object, or a slipping of a stair, or lifting, or a small jump can cause sudden pain in the back, which sometimes radiates around the flank. The pain is usually increased by turning on the bed or with the Valsalva maneuver, especially during cough or straining at stools. Bed rest usually gives temporary relief. By examination of these patients, usually they have a short stature. There is tenderness over the spinous process, the involved area, and the lower rib cage. Most of them have loss of height, and a typical Dowager's or the widow's hump can be seen. Along with this dorsolumbar kyphosis, we also have degenerative scoliosis in many of the patients. So when we come to the investigation part, so we get a lot of investigations, but most of the times the serum calcium is normal. Inorganic phosphorus is normal. Slight hyperphosphatemia can be seen for patients near menopause. Alkaline phosphatase is usually raised. And 20% of the postmenopausal women can have hypercalciuria. So the accurate measurements of this bone resorption markers will give us some idea how to proceed for the further treatment. When you have two types of markers, we have bone resorption as well as bone formation markers. So the resorption markers are usually urinary free deoxypyridolin, short form of DPD, urinary total pyridolin, UID, urinary collagen breakdown products, which are type 1 cross-linked N-telopeptides, urinary and serum collagen type 1 cross-linked C-telopeptides, CTX, and bone sialoprotein. The bone formation markers are usually done for monitoring the therapy, especially when the patients are given anti-osteoporotic treatments such as bisphosphonates or bone formation markers treatments such as parathyroid hormone in the form of Terifrace or Forteo. These are serum total alkaline phosphatase, bone-specific alkaline phosphatases, serum osteocalcin, and serum type 1 procollagen peptide. So how to monitor this and what is the treatment options according to the changes of this, it can be discussed in the further upcoming presentations. So once the basic X-ray, the radiology wise, it looks like this. We have two types of X-rays. Previously, we used to take normal X-rays. Now there are a lot of digital X-rays. The digital X-rays, usually they provide a sort of false positive things. The bone mineral density in young patients can also be looked as osteoporotic, but the normal X-rays usually show this. There is a overall decrease in the mineral density. There are prominent vertical striations. The end plates are usually seen prominently, and the disc space is usually increased, and it gives an appearance of biconcave or podfish type of appearance. And generally, these patients may have osteoporotic fractures, especially in the dorsolumbar vertebrae. Few cases with serial collapse of this vertebrae, like you can see the X-ray here, on 5th February, 11th February, and 12th March. This patient has presented to us with serial collapse of a vertebral fracture. Can you predict this type of collapse? So there is a study by Sugita et al. He has classified this early osteoporotic vertebral fractures into 6 types. Normal, concave type, where there is superior end plate fracture, the dentate type, where there is anterior cortex fracture and inward denting. There is a swelled type of fracture where there is anterior bowing, bow-shaped fracture in which there is both superior as well as anterior denting, and projecting type. So in all these type of fractures in which he has studied, the swelled front type and the bow-shaped type, these both type of fractures, when you see them on day 1, they have a chance of gradual collapse. So you need to have serial X-rays, and you need to warn the patient that it may go into further collapse and he may require a surgery. DEXA has been all known, a WHO recommended excellent modality of investigation with low radiation exposure and short scanning time. And it gives us a fairly good idea about normal osteopenia and osteoporosis. There are few drawbacks of this DEXA scan, especially in elderly degenerative cases where you have osteophytes, which give us a false positive result. So we need to take an X-ray and try to analyze or correlate with the X-ray as well as the DEXA scan. So next modality of investigation would be MRI scan. MRI scan is indicated especially when you have an fracture on the X-ray, and the X-ray can be serial X-rays can be taken, and sometimes you can take a flexion extension X-ray also, which gives us a fair idea about the fracture. Is it going into union or is it going to be a case of non-union? Right? If these patients may present with a dynamic deficit, which is when the patient is lying down, he is all okay, power is normal. But once the patient stands, because of the collapse of the vertebrae, there could be cord indentation. This is usually when the patient stands. So in such cases, you need to go for an MRI, and the MRI will give us a fair idea about the cord compression and a Camel sign, which is a seen when there is a non-union. And also these osteoporotic fractures, sometimes there could be associated pathology in especially elderly people over the age of 60. They may have metastasis, or there could be a secondary like multiple myeloma or a plasmacytoma or any other pathology that can be picked up in the MRI, and further we may need a biopsy to prove it. Thank you.
Good evening, viewers. I'm going to talk about the medical management of osteoporosis. Basically, what I'm going to talk about is sequential therapy which is necessary to tame this monster named osteoporosis. Let's know some facts. Let's identify this disease in the early stage, then we'll be able to manage it better. We need to educate patients and society, and in order to have that, we should have the database with the diagnosis of osteoporosis. We should really concentrate on the full course of the treatment, and regular follow-up has to be stressed at. And we should really talk to the patient, teach to the patient about the sequential therapy, as this is like the disease of age-related issues. And we should really identify the defaulters. From the discussion, we should be able to identify that this patient is not going to continue medication, and certain medications which we will discuss later on in the talk, which can have detrimental effect if they are not followed by the second line medication. So all these things has to be considered in the management of osteoporosis. It is underdiagnosed, it is undertreated, as we all know. One fragility fracture has occurred, second on its way, and we really stress on this, and we teach the patient that all the bones, they were born in the body at the same time. So why one has fractured? Because of the stress on that bone, but second, it are unanswered and and that is something which this webinar will certainly address to, and certainly
I think some internet issue from Dr. Dave's side. He'll be joining back shortly.
Okay. Shall I share the videos what sir was showing?
Yes, please go ahead.
From the beginning, sir, again?
From the beginning of sir's lecture.
Yeah, yes. Okay,
Yeah.
sir.
Yes, from here you can start.
Is it visible, sir?
Yes, it is visible.
Yes, it's visible, Chandraketu. You can start.
I'm going to talk about the medical management
Perfect.
of osteoporosis. Basically, what I'm going to talk about is sequential therapy, which is necessary to tame this monster named osteoporosis. Let's know some facts. Let's identify this disease in the early stage, then we'll be able to manage it better. We need to educate patients and society, and in order to have that, we should have the database with the diagnosis of osteoporosis. We should really concentrate on the full course of the treatment, and regular follow-up has to be stressed at. And we should really talk to the patient, teach to the patient about the sequential therapy, as this is like the disease of age-related issues. And we should really identify the defaulters. From the discussion, we should be able to identify that this patient is not going to continue medication, and certain medications which we will discuss in the later on in the talk, which can have detrimental effect if they are not followed by the second line medication. So all these things has to be considered in the management of osteoporosis. It is underdiagnosed, it is undertreated, as we all know. One fragility fracture has occurred, second on its way, and we really stress on this, and we teach the patient that all the bones, they were born in the body at the same time. So why one has fractured? Because of the stress on that bone, but second, it's going to happen because second is going to be as weak as the first one. Pharmacotherapy, we all know that it is a medical disease and it remains the mainstay of the osteoporosis management, and the available drug has to be discussed and has to be tackled and given according to the need. And several issues still are unanswered and remains a questionable as the effectiveness of anti-osteoporotic drugs in the clinical practice. This lack of awareness in the healthcare worker and healthcare providers has to be stressed at, and that is something which this webinar will certainly address to. And certainly the poor adherence to the therapy by the patients, again, it's a big challenge for all of us as well. The safety in the long-term treatment is going to be discussed, and at the moment what we are going to talk about the secondary prevention care, but I think in the future we should be considering the primary prevention care as well as far as this osteoporosis is concerned, because a lot more has been said, discussed in the medical fraternity about cholesterol, about the heart disease, about the diabetes, about the primary prevention, but not for the osteoporosis. So what is sequential therapy? Well, like diabetes and blood pressure, it's an aging disease, osteoporosis as well. And I would like to say this, love me or hate me, but think about me and remember me, and that is osteoporosis. And once diagnosed that somebody has got the osteoporosis, it's a lifetime treatment which is required and which should be continued for the lifetime. And drugs have the different action, and it's a limited time duration as well. That's what we should stress to the patient, and give the drug according to the severity of osteoporosis. And that's where the sequential therapy role will come. So I presume that the audience is aware of drug therapy which is recommended in the postmenopausal women. BMD, we know that, whenever it is less than minus 2.5, we calculate the FRAX, 10-year risk of the major osteoporotic fracture. And we all know that oral calcium and vitamin D, they are the mainstay of the treatment as well in all the patients having osteoporosis. I think we should really discuss and talk about how and what should be prescribed. So let's go to the normal bone metabolism. As we know that osteoclasts are important in order to stimulate the osteoblastic and bone formation, and that is what this diagram talks about. And we should really talk about the rank, which is a receptor, and rank ligand is something which is very important in order to activate the osteoclast, and that is where the rank is the receptor, and rank L will attach to it and will start the functioning of the osteoclast. That is where some of the drug are going to function as well. We all know that the resting cells, they become osteoblast, and it takes about 13 weeks for the osteoblast to lay down the bone, while 3 weeks for the osteoclast to resorb the bone. And this bone formation is initiated or fastened or activated by the parathyroid hormone chain, which is called teriparatide, while the activation is neutralized by denosumab because it attaches to the rank receptor. while the same thing, resorption, can be reduced by bisphosphonate as it attaches to the osteoclast receptor. So this way we can control the osteoblastic formation and osteoclastic resorption or activation of the cells. And that is where all these molecules will have different effect, and we should really use this knowledge in order to achieve the maximum advantage and give the maximum advantage to the patient. There are studies which are in the literature which we have included. I have included in this talk: Expose, Fact, Vero, Horizon, and all these studies, they are very well written in the literature and they conclude a lot of things. That's what I'm going to use in order to conclude my talk as well. So these are the clinical risk factors. As we all know that previous fracture, parent fracture, hip, current smoking, glucocorticoid therapy, rheumatoid therapy, secondary osteoporosis can be observed in patients who are taking clopidogrel. Even rifampicin is also known to cause osteoporosis as well. And certainly somebody who is taking the alcohol every day, it can also cause osteoporosis too. So before we treat osteoporosis, we really need to have the following investigations. One of them is the DEXA scan. Usually we follow the spine and hip, as we know that they are the weight-bearing bone. Obviously, one will have the basic blood test, serum calcium level, which we really need to know. If there is hypercalcemia, then we cannot start certain drugs like teriparatide. Serum alkaline phosphatase, that will also help in identifying the other disease and rule out the other disease. Hydroxyapatite vitamin D, hydroxyvitamin D3 is very important in order to identify the vitamin D deficiency. And parathyroid hormone, if the level is high, secondary hyperparathyroidism or even the primary hyperparathyroidism has to be ruled out in order to treat this, because the treatment will be completely different and investigation also will be different because of the parathyroid adenoma, which can give rise to osteoporosis too. Thyroid TTSH, serum protein, creatine clearance is very important in order to initiate the treatment, because glomerular filtration rate has to be identified and accordingly the dose should be titrated. What are the investigation which help us in monitoring? Well, the BMD is something which is to be done in the same DEXA machine, and bone turnover marker, they are helpful in monitoring the therapy. So let's come to one of the molecule which is, I would call this as a miracle molecule, teriparatide, and it is one of the most common anabolic drug which enhances the bone formation, and it is really laying down the bone by the osteoblast. It stimulates the osteoblast. Let's talk about the teriparatide. The positive parts of the teriparatide, it's something which stimulates the osteoblast, and the only drug that improves the bone architecture both cortical and trabeculae, and that is why I sometimes call this as a miracle molecules, have seen excellent outcome and results. The negative effect, it's a subcutaneous therapy which is costly and expensive molecule. Limitations are 18 to 24 months once in lifetime should be given, cannot be repeated second time, but also in clinical practice quite a few of us may have used it second time as well. And the compliance and the adherence to the treatment is again a big question, and cold chain has to be maintained, and serum calcium level, serum PTH level should be monitored and should be done pre-starting the therapy. Very important to remember this, and it cannot be given in malignancy because it is a hormone therapy. Bisphosphonates, they are most commonly used. It can increase the matrix mineralization and bone density to a certain point. They cannot restore the lost structure and substantially improve the bone architecture, but they certainly help us in resorption pits which are closed and they are not able to stimulate the osteoblast activity. Their compliance and persistent therapy, which is for the anabolic pool, is very important. Let's know what are the positive parts of the bisphosphonate. Well, it is cost effective. It can be given IV or oral. Alendronate is the most commonly used molecule and which is quite effective orally. Zoledronic acid can be given yearly IV therapy, and we should be considering in all these patients who are on bisphosphonate drug holiday after 3 to 5 years of the therapy for 1 year at least. And it causes the apoptosis of osteoclast. And we have to check creatinine clearance in patients with the chronic renal failure because the dose should be reduced too. But what are the negative sides? We know that it is a suppression of the bone turnover, and it explains the osteonecrosis of the jaw. That is where the bone turnover is reduced, and that leads to the jaw osteonecrosis and the atypical femoral fracture when it is given for the long-term therapy. Patient compliance is sometimes poor because it has to be taken empty stomach with a glass of water, and it can cause gastric side effect in the form of base of the esophagus, the ulcers too, because of the regurgitation. And a yearly therapy should be given, but then it can cause fever for a day or two. So when you give it in the post-operative period, if it causes fever, then we get confused with the infection or infective etiology when we are treating with the post-op patients. And drug holiday has to be considered. Coming to Denosumab, we all know that it is something which does not allow the osteoclast differentiation, and that is where it attaches to the rank. And the positive effects, positive parts of the Denosumab, once in 6 months it should be given. And the 10-year data is available, the 15 years data which soon is going to be published as well, and it is quite safe. There are no major lab tests required with the Denosumab therapy, and BMD increases faster, so you can monitor in the DEXA scan that the BMD has improved. But the negative side is if it is not repeated every 6 months, then 7th month onwards the BMD level will go down, and the increases chances of the fracture are observed more with Denosumab than any other molecule, and it has to be followed regularly. That's what we should be talking to the patient, teaching to the patient as well. And it is an injectable molecule, subcutaneous, though it is expensive, but not so expensive when you consider the 6 month therapy and when you compare it with the teriparatide therapy. The caveat is do not stop injection or else you start bisphosphonate. Otherwise, fracture risk will increase. So this has to be taught and discussed with the patient. And patient compliance and adherence to the therapy should be monitored as well. One considers the overall management of osteoporosis. Then we consider two factors, DEXA positive and clinical risk factors. And that way we diagnose that patient as osteoporosis. If patient has got fragility fracture, then preferred method is teriparatide, that's a bone stimulant, in order to have the osteoblastic activity and fill up the pot, which is empty. And one without fragility fracture, the preferred method would be for them would be to give the bisphosphonate or Denosumab osteoclastic suppressant. We usually tell the patient that you should put the alarm every 6 months. So coming to the real scenario in the clinical practice, teriparatide, we give it for 18 to 24 months. It's usually once in lifetime. It is contraindicated in malignancy, and we should monitor with the serum calcium and serum PTH level. Although it is a red level drug, but it was something we all know that it was given in the double dose in the rat for 3 years, and that's where it caused the carcinoma. So it is not the real red level in the human therapy as well. The cost and subcutaneous injection, they are the negative side, and cold chain has to maintain. While bisphosphonate 5 years, we should be giving drug holiday, oral or IV therapy, and we all know that jaw necrosis and atypical fracture are the main sort of disadvantage negative effects of the bisphosphonate. And in summary about the Denosumab, 10 years therapy, one should not miss the dose. Injection has to be given subcutaneous, and it can be given in the malignancy as well. We all know that a combined therapy can be given, but does it have additive effect? No, it is not like 1 plus 1 is equal to 2. It is never so. And sometimes, it gives only 20% additive effect as well. So, teriparatide to bisphosphonate or teriparatide to Denosumab, but Denosumab to teriparatide is not recommended at all. So from osteoclastic suppression to osteoblastic stimulant therapy is usually not recommended in the literature, and it gives the negative effect as well, or does not increase the BMD as much as it should. So in order to tame this osteoporosis monster, we should be giving the bone stimulant in the form of teriparatide. We should really fill up the pot of the bone, and by giving the bone stimulant in the form of teriparatide, followed by we can give bisphosphonate or denosumab. Either can be given, but we should be educating the patient bisphosphonate 5 years or denosumab 10 years. And this is something which we call it as sequential therapy, and it should be along with that oral calcium and vitamin D should be given too. We should be monitoring vitamin D level as well before starting the therapy, because vitamin D low can give rise to completely wrong and detrimental effect as well. So combined therapy, well, can be given, as we know, as we discussed in the previous slide, that yes, combined therapy gives only about 20% additive effect. Regarding this American Society of Bone and Mineral Research, ASBMR, this article in the editorial 2016 mentions that denosumab after teriparatide therapy increases the cortical BMD and the cortical thickness. But when it is given other way around, teriparatide after denosumab, there was decrease in the total BMD and cortical BMD as well. So this is to be remembered, that it should be followed by the bone stimulant and followed by the osteoclastic suppression. When diagnosed early, I think better manage with the bisphosphonate oral or IV. When it is, I'm talking about the early disease, not the severe or moderate osteoporosis or before the fragility fracture occurs. Many drugs have the region specific. Some have the more effect on the hip, some have the more effect on the spine. BMD of all the bone does not respond the same way. Very important to remember this as well. Decadurabolin, we cannot really forget this molecule. It is an anabolic, it is bone stimulant as well. It is injectable only. The only disadvantage is the weight gain, and the prostate cancer has to be evaluated. It is not widely used. Currently, we are doing the study on the decadurabolin as well, along with the anabolic effect and along with the alendronate and decadurabolin combination. This recent article published in Bone 2020, and it has concluded that non-bisphosphonate intervention studies were done, and they say that the clinical effectiveness of denosumab, raloxifene, romosozumab and teriparatide, they all are effective and they all give good benefit to the patient compared to placebo treatment. So in order to conclude something from this Bone 2020 article, that all this therapy should be given in moderate to severe osteoporosis in order to prevent the second fracture, which is going to happen in practically all these patients, as the skeletal is not strong enough to withstand the forces. And this study was concluded after 7,000 cases were evaluated. As discussed earlier, I want to stress again that after stopping denosumab, we should start bisphosphonate therapy, otherwise bone loss will occur fast. Should we ever consider stopping the medication for osteoporosis? We should never ever stop medications. We must continue with vitamin D and calcium. Once diagnosed low BMD, we should check it yearly, but after restoring the BMD, we should certainly continue to maintain that raised BMD, and by giving bisphosphonate and with the drug holiday for 1 year. And we should keep monitoring all these patients too. In the medical management, along with the bone loss, we also should consider the muscle loss, and that is called sarcopenia. The muscle mass is also evident in the elderly patients as age increases. And this is the fact that when we are at the age 60, the 25% muscles have gone, but when we reach to 80, about 60% sarcopenia is observed as well, and that is where the frequent fall occurs, and that's where the fracture also occurs. You can see in this image at the age 25 how much was the muscle around the femur, and at the age 63 that muscle has completely gone. and nearly replaced by the fat around it. So the thigh girth has remained the same, but the muscle mass is lost. Same way, we also observe in the paraspinal MRI muscle mass. As you can see, the muscles are seen very well here, and then the same muscle, as you can see, that there is fatty infiltration of these muscles into the paraspinal area, and that's what leads to the frequent fall too. And that is where we should be considering sarco-osteoporosis or sarcopenia osteoporosis. Age-related bone loss, age-related muscle mass, and that's what gives the fall, fracture, morbidity, and mortality. Still, issues remain unresolved in the management of osteoporosis. Are patient education and awareness and adherence to the treatment. Resistant osteoporosis we have observed in few cases where nothing works and patient continues to have osteoporotic fracture. Atypical fracture and jaw necrosis remains unsolved, and many therapies are parenteral route, and cost remains a major issue when it is a challenge to give the osteoblastic drug. And Indian data, we have limitation. Along with the studies mentioned, they have their own limitation, and we sometimes feel that they were all sponsored studies. So my take-home message is early diagnosis, educate the society, consider the full course. I think sequential therapy has to be taught, discussed in all the forums as well, and we should really identify the defaulters and helps in preventing the disease. So ideal would be oral calcium vitamin D. The caveat is vitamin D. It's a fat soluble vitamin. And when you overdose it, I think something which should be thought about, we should be discussing as well, not to overload vitamin D because it's a fat soluble. It will remain in body for long. Teriparatide maximum one can give 2 years, but it has got the the subcutaneous therapy, and repeat dose one cannot give, but something which may be given by quite a few of us have observed that we have given teriparatide as a second treatment option as well. Denosumab 10 years, we know that discontinuing denosumab will drop the BMD, and bisphosphonate, we know that drug holiday is required, otherwise there will be pathological fracture. And combination therapy, well, I think still evidence is not there to start the combination therapy. About 20% additive effect is observed. Thank you for the patient's hearing. Now over to Dr. Dilip Sengupta, who has joined from US in order to give his talk on the surgical management of osteoporosis. Thank you.
Chandraketu, can you play the Dr. Sen Gupta's presentation, please? Chandraketu.
Yeah, doing.
Please.
Good evening, ladies and gentlemen, and good morning from Dallas, Texas. The challenges of spine surgery in osteoporosis can be of three different types. The first one is the osteoporotic vertebral compression fracture. And this can lead to deformity as well as neurological damage, poses another challenge. And everyday surgery for spine, when it is done in presence of osteoporosis in elderly, then it becomes challenging. Let us deal with it one after the other and come up with a clear message for all of these three factors. The first and foremost is the osteoporotic vertebral compression fracture. This has been recognized for many years, and people in the past have tried to do mini open vertebroplasty, which used to be done infrequently and is very rare these days. But percutaneous vertebroplasty, by putting a needle into the lesion in the vertebral body and injecting cement into it, was first reported in 1984 in a small city in France by Mathis and Balkov and Deraman. Following this report, multiple reports were there for injecting cement into vertebral body region, but at some point during 1980s, people started injecting cement into acute painful osteoporotic vertebral compression fracture with pleasant surprise that the pain resolves almost immediately. And this has led to a very widespread use of vertebroplasty. People started recognizing the side effect or the complications like adjacent vertebral compression fracture, or more importantly, cement leakage into vein that can go to lung or into spinal canal and leading to paralysis. To prevent that effect of cement leakage, kyphoplasty was originated, where you inflate a balloon into the collapsed vertebra to make up some room and fill in that void with cement, minimizing the chance of cement leakage. As an added benefit, you can possibly restore the vertebral height to some extent by using the balloon, and that coins the name of kyphoplasty. There is no good proof or good study establishing that kyphoplasty can restore the vertebral body height, although in some cases it can do, as you can see in this example. The real challenge of vertebroplasty or kyphoplasty is the cement leakage. When it leaks into bone, into veins, it can go into lung, like in this patient, one of mine, where a lot of cement leaked into the pulmonary artery, and a few weeks later we lost the patient. This is a life-threatening complication. But more frequently, cement can leak into spinal canal, and if it is large enough, may cause paralysis. Cement leakage along the nerve roots can cause intractable radicular pain. The leakage usually happens through the central vein of the vertebral body. There are several techniques one can do to prevent excessive cement leakage. If you're using a piston and syringe filled with cement like this, you can dip it in warm water to make it a quick setting for the initial injection of cement to prevent cement leakage. The other techniques are point the nozzle towards the end plate, which is not fractured, and less chance of cement leakage. If you find tiny amount of leakage, you stop injecting any further cement and let that small amount of cement to solidify, and then keep on injecting behind that cement, minimizing further cement leakage. Or you can work on the other side if you find cement leakage from one side. There are other techniques, like if the nozzle for injecting cement is flexible, then you can bend it away from the area of cement leakage and continue further cement injection. Whatever you do, you have to be very careful to prevent any cement leakage. You can do using only one C-arm, but the cement leakage may not be visible in one plane, and to prevent that complication, it is preferable to use two C-arms simultaneously. We first position one C-arm in the lateral position and drape over it, and then bring another C-arm on top of it to perform vertebroplasty, so that every drop of cement that is injected is immediately checked with both AP and lateral plane. In August of 2009, after the vertebroplasty has exploded to a very large number of people doing it in large quantity, and people realizing the complications, there were two articles were published in New England Journal of Medicine. And both these articles concluded that we found no beneficial effect of vertebroplasty as compared to sham procedure or compared to non-operative treatment. And this took the surgeon community by surprise, because most common experience is that vertebroplasty take care of pain almost immediately after injection. Whether the pain relief is due to additional support of the trabeculae with cement or killing the nerve endings or pain fibers in the trabeculae, it is not clear, but it is very clear that the pain relief is almost immediate. And this debate went on more and more, and more recent articles establishes that beyond doubt, vertebroplasty is successful to relieve pain in acute osteoporotic painful vertebral compression fracture. The take-home message is that while it is very effective, it is potentially dangerous. Use 2 C-arms simultaneously, watch for cement leakage and stop before it leaks more, and do no more than 3 vertebrae at one session to prevent excessive cement leakage into pulmonary arteries. The next challenge in presence of osteoporotic fracture when it leads to deformity or kyphosis with or without neurological damage. This is reasonably common in this unfortunate young lady of 45 who had deformity, and finally we had to do something, and we answered soft, but the correction did not last long. Within few months, this kind of experience is reasonable. Who originally had osteoporotic vertebral compression fracture treated by a small laminectomy, and that the posterior element or the lamina are relatively unaffected lamina in presence of anterior vertebral collapse. The entire spine lady developed not only paralysis but bladder and bowel incontinence. So we had to do surgery. We did reasonably extensive surgery. Distally we went to pelvis, and she had a reasonably good ambulation for few more years. This is not an isolated older osteoporosis, had osteoporosis, but later on developed kyphosis with neurological deficit and cord compression. We corrected it with a combination of long segment fixation, cemented screw at the caudal end, caudally directed screw at the cranial end, and also another device called sublaminar tapes. These sublaminar tapes are much more resistant to cutout of the lamina compared to sublaminar stainless steel wares, and we had a reasonably successful outcome, and the patient was happy, regain neurological status, and be ambulatory and pain-free. This is another example where we have used cement-augmented screw caudally and cranially in addition to sublaminar tapes. This kind of successful story are not uncommon. Like in this lady, 79, regained her ambulatory capability, but 3 years later, from cardiac complication not relevant to kyphoplasty, she died, and we received a letter from her son who said, "Thank you very much for giving us years of her thin surgery. Mom rarely had any pain, and she had a much better lifestyle than she had years prior to kyphoplasty." We had similar experience published from Mumbai by Dr. Uday Power and Dr. Abhay Nene and his team, and they have suggested different kind of surgical intervention to supplement laminectomy. But the take-home message is that never do laminectomy alone in osteoporosis. And the last challenge is regular spine surgery in osteoporotic bone. This is not uncommon. Like in this patient, restored sagittal balance with pedicle subtraction osteotomy, in no time developed proximal junctional kyphosis with screw cutting out of bone that was repaired with further cranial extension of fixation with some kyphoplasty in the adjoining vertebra. But still that fixation failed and patient went into proximal junctional kyphosis. This is a frequent problem. In this unfortunate lady who was 68 with osteoporosis, went to a world-famous surgeon, very famous for doing disc replacement, and he treated degenerative back pain with disc replacement in front and flexible device at the back, causing 360 stabilization. But because bone was osteoporotic, started developing compression fracture, which collapsed further, and surgeon was not intimidated but did a corpectomy, used a Moss cage in front of the vertebra for replacement of the vertebral body, which is notorious to cut into the bone, and in addition did a flexible device or coflex at the back, interspinous device, and extended the fixation cranially. But that did not stop for misery. She developed further proximal junctional kyphosis as well as kyphotic deformity distally with pain throughout the back. We had to do surgery on her, and after exposing, we found that the cranial end developed an acute kyphotic deformity, and caudal end had the interspinous device and also a flexible spring kind of a device at the caudal end. We removed all of these devices and connected with a long construct, and essentially we did at the cranial end a caudally directed screw and hook combination, and this combination actually provided a lasting relief, and she was very happy even at 6 years post of follow-up. However, not always we get good outcome with caudally directed screw and hook combination, and it can fail, like in this lady, further cranial to the fixation, developed osteoporotic vertebral compression fracture, failed with kyphoplasty, and we had to extend it further higher up with caudally directed screw and hook combination again. Other option is to do cement augmented screw, which can be done simply by doing a vertebroplasty before putting screws, or you can use a fenestrated screw, either fenestrated towards the tip or towards the middle of the shaft to give some rigidity of fixation. And in this case, where the hook and screws both failed with subsequent osteoporotic fracture, we revised it with cement augmented screw. Another example of cement augmentation is that we used both cranially and caudally cement augmented screw in combination with the sublaminar tape with successful outcome in this elderly lady. In degenerative back pain coupled with sacral osteoporotic fracture, when we had to do surgery, we used cement augmented fixation, including pelvic fixation, with reasonably good outcome. However, regardless of cement augmentation or caudally directed screw or sublaminar tape or hooks, none of these would survive unless you treat the osteoporosis promptly, both before surgery and after surgery. Prepare the patient with medicine before surgery. And we use Teriparatide, which is a reasonably quick-acting medicine. This is similar to parathormone, which is 84 amino acid polypeptide, and the first 34 amino acids in the amino end is the active ingredient of this polypeptide that can be synthesized in laboratory, and that makes teriparatide or Terifrace. They combine with precursor of osteoprogenitor cell to differentiate into osteoblast, causing quick laydown of bone. And in our practice, if we treat the patients prior to surgery for at least a month, preferably 2 months, to enhance fusion and also enhance fracture healing, besides treatment of osteoporosis. Another similar drug, besides bisphosphonate, which is age-old drug being used for treatment of osteoporosis, is Denosumab, which acts differently. While bisphosphonate adheres to bone and stops osteoclast to resorb bone, but Denosumab actually kills the osteoclast and blocks the formation of osteoclast. And it is much faster acting drug with a rapid onset of action and shorter half-life compared to bisphosphonate, making it more effective not only in the treatment of osteoporosis, but also in the treatment of giant cell tumor and similar other bony lesions. To summarize, Surgery in osteoporosis is challenging. For osteoporotic compression fracture, remember kyphoplasty is potentially dangerous and watch for cement leakage. Kyphosis and stenosis in osteoporosis is common, but do not do standalone laminectomy. And most importantly, while performing surgery in osteoporotic bone, do not forget to treat osteoporosis with medicine before and after surgery. Thank you very much for patient hearing.
CK, can you hear me?
I can hear you. I'm Dr. Sengupta here.
Sir, good evening, sir. Good evening. CK, just play the 5th video.
Before we start our question and answer session, I have an announcement to make. Today's guest speaker, Dr. Sen Gupta sir, has expressed his eagerness to help patients in India. Sir is now available for telemedicine consultation through this website, centerspine.in. So when we go to this website, centerspine.in, this is the homepage which gets displayed, and there is an option for book an appointment. If we click on book an appointment, this is the page that gets displayed, which shows the preferred method to be through HealthPlix application. The method to be followed has been explained on this page. The other options available are through WhatsApp as well as through email. So those of your patients who wish to consult Dr. Sen Gupta sir can be guided to this website, centerspine.in. I'm sure our patients will be happy to take the benefit of this opportunity. I would, hello.
Hello,
Yes, we can hear you, Dr.
Yeah,
Ravi.
yeah. I would like to thank all the speakers for excellent informative talk. We have a few questions now. We'll move on to the question and answer session. The first question is for Dr. Devanand sir. A young 39-year-old female is asking that she is complaining of back pain and she was advised to go for DEXA scan as the doctor suspected osteoporosis. What is your understanding and what is your advice on this, Dr. Devanand?
Yes, very good evening. Excellent question, and which go with a digital X-ray, and these digital X-rays are usually giving us a false impression of osteoporosis, and the general practitioners who see this will suspect osteoporosis. But I would strongly tell the recommendations for DEXA scan. Most of the DEXA scan are done for elderly women more than 60-65, which are who have undergone menopause and postmenopausal stages, and in males more than 70 years. So the back pain in young patients is not commonly because of osteoporosis. It could be of other causes. So the clear indications are elderly females and elderly males over 70 years. DEXA scan should be performed, not in young patients. Thank you.
Bharat sir, would you like to add something to this?
Yeah, I think for a young patient, the Z score is something which is of value, because for young patient, for the secondary parathyroidism or secondary osteoporosis, we really need to evaluate. And probably that's one of the modality which will help us in evaluating the treatment plans. Basically, how the response to the treatment is going on. So that is where the Z score has the value in the younger population.
Thank you, sir. Another question is...
I think I'd like to add, if you permit me to.
Please, sir.
What I'd like to add is that osteoporosis is very typical in people with a very low BMI, like BMI around 20, 22, very thin people. In young people, it is very rare, but if the patient has end-stage renal disease or patient is taking medicines which can cause osteoporosis like anti-seizure medicines like phenytoin, etc., or patient take long-term steroid for asthma treatment, then you can certainly suspect presence of osteoporosis contributing to back pain. But in absence of any of these predictor, in a young healthy person, the back pain should not be suspected causing from osteoporosis. Osteomalacia, on the other hand, is more frequent in the younger population rather than osteoporosis, and it has got its specific indication and different modalities of investigation. Thank you.
Thank you, sir, for the clarity. Another question for Dr. Devanand, sir. The viewer wants to know, do we need biopsy in every case to diagnose osteoporotic fracture?
Yes, as I have elaborated all the investigations that are to be done to the osteoporosis, the biopsy is not indicated in many of the cases. But if there is an elderly patient whom on X-ray and MRI, we suspect some secondary cause of osteoporosis, and these elderly patients may have unknown pathological fracture that could be secondary to osteoporosis, or that could be secondary to plasmacytoma, multiple myeloma, or sometimes secondaries. They could mimic osteoporosis in few of the MRI images. So those patients need to be subjected to biopsy, but not the regular osteoporosis for biopsy. The DEXA is still a gold standard for diagnosing osteoporosis. Thank you.
Okay. So in cases when we are suspecting some other pathology other than osteoporosis, Sir Bharat sir wants to add something.
Yeah, I think as far as the biopsy is concerned, that is to be reserved. That is why we really have the, in our hospital in the Savia, we have the osteoporosis evaluation, the bone profile, the blood test. And that certainly helps us to rule out the secondary osteoporosis. So if that is suspected, or a patient has got previous malignancy, I think that's where we really do not sit and then we go for the biopsy. But what Dr. Devanand said, not for all of them, we need the biopsy.
I think I can add from the surgical perspective, like when you do a kyphoplasty, we can do the biopsy immediately just before injecting cement. But even then, we do not always obtain the biopsy if the patient has multiple fractures and already established that it is simple osteoporosis as not a bone tumor. But if you are not sure, then certainly we obtain the biopsy. And the other point is that biopsy is not the diagnostic test to establish osteoporosis. But if you'd like to differentiate between osteomalacia and osteoporosis, or in combination, or to rule out any secondary disease of the bone, particularly malignancy, like multiple myeloma or metastatic tumor, then the role of biopsy do come in. Thank you.
Yeah. If I may add about the vertebroplasty, I think before subjecting a patient for vertebroplasty, we always go for the urine routine micro. And if patient has urine routine micro positive, then probably we should treat UTI as well. Or along with that, first, and then we go for the vertebroplasty. There are cases which has, we have found the dissemination because of the venous, there are no beds and plexus, the valves, and that's why they can end up with that. And we also have had surprises in the vertebroplasty cases where it turned out to be the positive culture when we aspirate the fluid and send it for the evaluation.
Thank you,
I
sir.
think this is a very, very important point, because the last thing you want that you injected cement in vertebral body and that gotten infected, because there is no good way to get rid of it. Thank you.
The points well taken. Any underlying focus of infection must be ruled out before vertebroplasty, and in any suspected case, before injecting cement, a biopsy must be taken from the fractured vertebrae. Thank you, sir. Next question for Bharat Dave, sir. Why did you say that you always need to check blood serum calcium and serum PTH levels before beginning treatment with teriparatide?
This is the message we really want to give it to the esteemed crowd, all the surgeons, all the physicians, everybody who is treating osteoporosis, because we have found in n number of cases secondary hyperparathyroidism, vitamin D deficiency, and serum calcium level which could be low or which could be high. We know that in order to boost the osteoporosis management, we usually start filling up the pot with teriparatide. And if hyperparathyroidism is there, we cannot give teriparatide. If hypercalcemia there, we cannot give teriparatide. If vitamin D is low, we have to correct that first before we start the treatment. So that is where we really should have the serum calcium level and serum PTH level have to be monitored. I would go to that extent that we at our center usually are able to diagnose one adenoma every 6 months. So we have that high index of suspicion, and we are able to treat these patients for the adenoma by the surgical management. So that is where, I really want all of us to really investigate, and we all should have the basic bone profile before starting any therapy and in order to rule out the secondary causes. Thank you.
I think this is a very, very important point Dr. Dave has raised. And I'd like to add that the mechanism of action of teriparatide is to give an intermittent high dose of parathyroid hormone. But if the person already has got a high parathormone level in their blood, then you cannot make any changes by giving the teriparatide injections from time to time, because the parathormone hormone is already high. So it's not going to work anymore. So you have to establish that patient doesn't have a hyperparathyroidism before you can expect teriparatide is going to do any good. Thank you.
That's right, sir. Another question?
Yes. Yeah, I would just add that is where the Denosumab is helpful, because then Denosumab, you probably do not need to do any other investigation. And as we know that, it's a rank and rankle. So that is where, Denosumab, although it is osteoclastic and it's not going to fill up the bone, but it will certainly reduce the bone resorption.
In fact, Denosumab will also help to prevent further bone destruction with the hyperparathyroidism. It's a treatment for hyperparathyroidism.
That's right. Another question for Dr. Sen Gupta, sir. Is osteoporosis like hypertension and diabetes that need lifelong treatment? Because we just heard sir speaking about sequential therapy.
Oh, yes. I think this question should be more directed to Dr. Bharat Dave. And as he has very clearly explained the medical treatment, the treatment for osteoporosis is lifelong. The surgical intervention for osteoporosis are just temporary, like when they develop a painful fracture. Even if they have developed a fracture, which is not painful because it is already collapsed and it is old, there is no role for any surgery unless you are correcting deformity, etc. But the medical treatment for osteoporosis, to my mind, is for lifelong. And maybe Dr. Dave may explain it better.
Yeah, I think the medical management remains the mainstay. It's a medical disease, one can say, osteoporosis. And surgery is, as Dr. Sen Gupta said, it is for the painful condition, painful vertebral or the osteoporotic fracture. Medical management has to be discussed, has to be taught, and has to be taken to the last level. And that is where the sequential therapy word comes. I think this should be addressed to, for all of us. We really need to know that. Thank you. Thank you.
Thank you, sir. Another question is for Bharat Dave, sir. How do you monitor the effect of drug therapy?
Normally, we have had, the bone markers tested, but then bone markers have to be taken at a specific time by the specific lab and has to be considered. So we initially started doing it, and it's a bit of expensive way as well. So that is why bone markers we do not do anymore. We go for mainly the DEXA scan. If the DEXA scan doesn't drop, it remains the same, then we say that the treatment is working. If it drops, then we usually consider patient defaulter, or we change to the medication in the form of teriparatide, or we add or we start the dual therapy as well. As I mentioned, 1 + 1 = not 2, but 20-30% increase into the additive effect. So that is how we do. So monitoring mainly the DEXA scan and patient symptoms and signs. you may add, Dr. Sen Gupta. Is there anything else you use?
No, it is very well explained by you. I can only add what we do from the surgical perspective, that if the patient has osteoporosis, we give treatment for at least 4 weeks, if not 8 weeks. And we continue the treatment even after surgery. And if you treat the patient's osteoporosis before any planned surgery, either for degenerative back pain or for deformity correction, giving 2 months of teriparatide makes a big difference. Even for enhancing spinal fusion or treatment of fractures, even in long bone fractures, it has been shown in certain studies that teriparatide do help in bone formation to fracture healing or spinal fusion. Thank you.
Thank you, sir. For Bharat Dave, sir, another question is, sir, what is the role of strontium and calcitonin?
Strontium, it is not something that really increases the BMD per se bony architecture. It deposits into the bone, so BMD will in architecture. So that is why, the strontium is not something which is recommended. Calcitonin nasal spray, usually one can say that yes, nasal spray is helpful in prevention or other reducing the pain. As we know that calcitonin is it increases the vascularity. So that way it helps in reducing the pain. There are concerns worldwide about it. It is carcinogenic. If you give it for maybe a month or two, then it is not something which really, is worrisome. But that's what we practice at Stavia, that we give it for a few weeks and afterward we stop it.
Can I ask a question to Dr. Dave, please?
Yeah, please, sir.
Yeah, so one question is, like the last thing you said about the calcitonin, it usually comes from salmon and it's a foreign protein. And to my old knowledge is that people quickly develop antibodies, so it doesn't become effective after giving initial couple of months. Is that your experience too?
We haven't found that. No, we have not, to be honest with you, we have not to that stage, where we would really worry about that. But yes, that is always a concern about that salmon. Yes.
And the other question is, you mentioned that teriparatide is only once in lifetime treatment and you cannot repeat the treatment later on, or you cannot institute teriparatide treatment if you have already treated with either bisphosphonate or denosumab. I didn't have that knowledge. Can you throw some more light on it, why it is so?
Yeah, why it is so, I do not have the answer, but that is the recommendation by the pharmaceutical companies. They advise not to give it because it is a hormone. And I have had a couple of patients where by mistake it was started in the malignancy. It turned out to be malignancy afterwards. But then we stopped, immediately we realized. So they do not recommend in the patient with the malignancy. That is one. Why not to give second dose? We do not know. But I have few cases where I was forced to give teriparatide second time. Even my mom, I gave it to her second time after full complete dose. And till she lived, she never had any other fracture. So that is something I'm sure, a lot of people, they do that as well. So when the bone drops down, bone BMD drops down, sometimes we are forced to start the second time the teriparatide.
Yeah, because I would like to add here that either denosumab or bisphosphonate, they stop bone resorption. It cannot improve the BMD to the baseline. So whatever your BMD is, it can keep it there. Only the naturally available osteoblast will lay down bones, so the BMD improves very slowly, as opposed to teriparatide, which is actively forming bone. So you are enhancing the formation of bone. So to see a real increase in number of BMD would be very slow in DEXA scan if you treat only on the stop resorption side of it. Is that correct, Dr. Dave?
Yeah, I think you're right. Regarding the denosumab, I think that is something which we really need to talk, which I already have mentioned in my talk as well. Denosumab can be given for 10 years. And I asked the patient to put the alarm every 6 months. If you miss the dose, then the bone resorption occurs very fast. And that is where we really need to tell all the patient, and we really need to inform relatives as well that second dose is to be continued, is to be given. If not, we start the bisphosphonate. That is one. Second thing, in the Denosumab therapy, we have found to some extent increase in the PTH level, meaning it lays down the bone very fast, and we have observed that the BMD also increases post Denosumab therapy. There has been some debate going on. It also stimulates the parasite hormone production as well. So I'm not sure if this debate will go on in the literature, but in our experience, Denosumab has to be given. It can be given for 10 years. The literature is also coming up now 15 years as well.
Yeah, it's very well explained. I would like to add one caution. Like, I live in a society which is very litigious. So before instituting Teriparatide, we always tell them that it has been, at least in laboratory rat, proven to initiate malignancy. So if you have any worries at all, then it is your choice, do not use it. We have to tell the patient, although it has never been established in human being to cause any malignancy. Certainly, if it is parathyroid adenoma, it is contraindicated. But even in any other malignancy, particularly the breast cancer survivor or uterine cancer survivor, or for that matter, any person who has cancer in their family, in those patient population, I find they're very, very afraid, even if the risk is negligible or never proven. Thank you.
Sen Gupta sir, I would like to know, this is just a verbal explanation that you need to give, or is there a need for a written consent as well?
That is a secondary question. We do not do any written consenting for that. And even if you have to go to court, whether you have got it written or verbal, it really doesn't make any difference. In your informed consent for surgery is different, but we do not make any similar written informed consent like we do prior to surgery before initiating the medical treatment with teriparatide. But if we are treating them with kyphoplasty, that is considered as a surgery, patient has to sign a written consent, and it's a part of the written consent that you will have to be treated medically with teriparatide or other similar medicine. But only medical treatment with teriparatide, we never obtain any written consent. I don't think it helps.
Okay, probably this would be the last question for the day. The question is for Sen Gupta sir. So you showed us surgeries which were long, risky surgeries, osteoporotic bones. Are there any specific protocols for post-op rehabilitation for these patients?
Well, that's a very good question. When we do a long fixation, it is important that if the screw perches in the bones are soft, or you are making it a little stronger with adding some cement, but you can also make the anchorage stronger by increasing the number of screws. So in osteoporotic bone, you do not do a short segment fixation, you have to do a longer segment. That is one. And the posterior elements are stronger. That's why we bank on either hook or sublaminar tapes, because the lamina are much stronger than the vertebral body. And the post-op protocol is, besides the internal fixation that you have done at surgery, we give a brace all the time until the bone is strong enough. And particularly, we continue the treatment with teriparatide, and in another 6 months' time, bone becomes stronger. So if you keep the external stabilization using a brace and emphasize with the physical therapist and inform them that not to start mobilization like bending forward too soon, because that can cause the distal junctional failure of the iliac screws or sacral screws cut out easily if you bend forward before 6 months' time. So those are the post-op things that we monitor, that A, the patient is using a brace, B, patient is not starting mobilization exercise soon, and most importantly, that patient continues treatment, medical treatment for osteoporosis with teriparatide, with or without subsequent Denosumab or Fosamax.
Thank you, sir. That was a very clear answer from you. I would like to thank all our speakers, Dr. Bharat Dave sir, Dr. Devanand sir, and Dr. Sen Gupta sir, our patron Ajay Krishnan sir, my colleague Dr. Shivanand sir, and of course Intas for making this webinar possible. I would like Bharat sir to give a concluding remark.
Yeah, thank you very much. I think our zest for the management of the osteoporosis continues, and today being the Osteoporosis Day, World Osteoporosis Day, we were able to conduct this webinar with the help of Dr. Sen Gupta, who kindly joined from Texas, and along with the INTAS team. Thank you very much. And we all know that with all our efforts, the disability can be reduced to a great extent. Morbidity certainly can be reduced, and mortality can be minimized as well. Thank you very much. I think now over to Mr. Javed.
Yes, sir.
Yeah, thank
Warm
you.
good evening. Yeah, thank you, sir. Warm good evening to everyone. On the outset, I wish you all, on my personal behalf and company's behalf, a very happy Navratri. And I hope you all are doing well, safe and healthy in these unusual times of pandemic. Osteoporosis is a silent disease, but we should not remain silent about it. Today, to commemorate World Osteoporosis Day, this wonderful webinar titled Stand Tall Against the Silent Killer has been organized under the aegis of Stavya Spine Hospital and Research Institute, Ahmedabad. We have heard wonderful presentations. There have been a lot of take-homes as well. Every time, every program, so much has been heard, but still there will be few take-home points which will be really worthwhile. In fact, I would like to express my thanks to Dr. Devanand sir, who took us through clinical features and investigations. Dr. Bharat Dave sir, as far as osteoporosis is concerned, he is passion personified. Love me or hate me, but think about me, remember me. I think this is a wonderful phrase, take-home message he has given us. Thank you, Dr. Bharat sir, for removing a lot of myths that was clouding the medical management of this. Once more, sir, quoting you, monster disease. Thank you very much, sir, for that wonderful presentation of yours. And Dr. Dilip Sen Gupta, sir, thank you so much for sharing your wonderful work on those challenges in spine surgery related to osteoporotic fractures and making this program a wonderful in terms of scientific dissemination. I'm sure this program would not have been success without our moderators, Dr. Ravi Rai sir and Dr. Shivanand sir, and patron Dr. Ajay Krishnan sir, who gave their valuable insights in this wonderful program. As you all are aware, this program has been broadcasted through OrthoTV, and I would like to express my thankfulness to Dr. Ashok and his team as well. As Dr. Bharat Dave sir has shared, miracle molecule Teriparatide, which we launched in 2010 IOCON. From then on, this has been a wonderful journey for a decade right now. And to make this particular World Osteoporosis Day special, we have reduced down the price of Teriparatide, our brand Terifrace, to make it more affordable to your osteoporotic patients, sir. And in addition, sir, for all your patients whom you recommend Teriparatide or Terifrace, we are, with your consent, we do a free P1NP test at baseline as well as after 6 months, but only with your consent as well, sir. So this is our way of partnering with you in terms of providing better healthcare and also scientific knowledge to both healthcare providers as well as the patients as well, sir. I would just take last minute, sir. On World Osteoporosis Day, the theme this year is been to alert to risk factors and need for effective post-fracture care. So on World Osteoporosis Day, we join hands together with all the healthcare community of India to urge authorities to prioritize bone health and ensure effective post-fracture care for all older adults who have sustained fractures. This is the key to reducing down the burden for osteoporosis-related fractures on patients, their families, societies, and around the world. So thank you very much once again. It has been a wonderful program to commemorate World Osteoporosis Day, but we will not stop at only this. I'm sure, sir, with your valuable support and your partnership, we can take this knowledge stream forward as well, sir. Thank you very much for the opportunity, sir. Thank you, sir. Thank you.
Thank you very much, everybody.
Thank you, Dr. Sendhu. Thank you. Thank you for joining us, everyone, and have a wonderful
evening. Thank you very much, sir.
Thank you.
Thank you, sir.
Thank you, sir. We close this. Dr. Ashok, can we close this meeting?